Assalamualaikum. Sorry for the inconvenience. So let's continue. So for you people, for undergraduate, J point is generally not important. It's basically the starting point where you can have an ST elevation. So this was all about the normal waves. Let's move forward. All right. So shifting gears, and now here we are going to see something important when you are going to calculate the rate. The normal rate is basically between the 70 or 60 to 100 beats per minute. When it is going to be above the 100, it is going to be a tachycardia, and it is below 100, it is going to be an bradycardia. Right? So the normal heart rate for you undergraduate level, it is very simple to remember, very simple to follow. You just have to follow the large boxes. All right. You can calculate through these method, but if rhythm is a regular rhythm, you can calculate through the if you are from the QRS complex when falling on the large box. All right. So if a QRS complex is going to fall on this large box, the next one or the first large box, like these two QRS complexes are falling on the only one large box, then heart rate is going to be 300. And again, if it is going to fall here, then it is going to be 300. But if it is going to fall on the second QRS, second large box, it is going to be 150. All right. If it is going to fall on 1, 2, and 3, and 3 here, 3 large boxes, it is going to be what? It is going to be 100. All right. This is again a fact you need to remember that 300 if falling on the next first large box, then 300, the next large box 150, then 100, then 75, then 60, then 52, then 42, then 40, and then 35. All right. The second method, which you are going to see here in this slide, that is going to be you need to calculate that. Most of the time in the exam setting, you generally don't have time, and if the rhythm it is a regular rhythm, generally count the large boxes. All right, that is going to give you an accurate answer. But if you have time, if you have access to calculator or you're good in mathematics, then you can also use this method also. This method tells you about the large boxes when between two QRS complexes, between two R complexes, you need to calculate, you need to count the small boxes, and you need to divide that small boxes with the 1500. Now here the 1500 is the constant, and the R between two RR interval. If I'm going to take this one and this RR, between these two R complex, we have 10 small boxes. All right. So you are going to divide that 10 small boxes, and you are going to get a rate of 150. All right. And if you are going to divide, you are going to calculate this 5 and divide it with the 15, you are going to get the rate of 300. All right. So again, this is for you if you have time. Generally, if you don't have time, remember when the QRS complex is falling, you need to generally calculate the rate. If here 300, if 2, then 150. Now 300, 150, 100. If falling on after a 4 large boxes, then 75, and so on so forth.
Dr. Ahsan, you're not audible.
Okay, I'm checking what's the problem. Hello, Assalamu alaikum. Am I audible now? Okay, that's great. I don't know what happened to my microphone. It just all right. Okay, moving forward. So we are going to. So this is 12 lead ECG, just normal looking like this, and just I'm going to tell you only two things here to remember. All right. One thing is that AVR is going to be negative always. The P wave is going to be negative. The QR is going to be a negative, and the T wave is going to be negative. If any ECG have a positive P wave, positive QRS complex, positive T wave in the AVR lead, then that is abnormal. There are going to be two possibilities of that. If there whether the who have done the ECG have placed the leads wrongly, all right, or second scenario you can have a dextrocardia. Okay, so the first point in the normal ECG, toilet looking like this, AVR is going to be negative. If it is not negative, positive, then that is going to be limb lead reversal. Or second, can patient have a dextrocardia? So dextrocardia is basically the apex of the heart is normally on the left side. The apex of the heart is going to be on the right side. That is called as dextrocardia. Another thing is going to you going to remember here, the V1 is going to have a dominant S wave. So this negative thing is called as S wave, and the V6 is going to be have dominant R wave. Slowly as you go down from V1, V2, V2, V3, V4, V5, V6, the R wave is going to be dominant, the S wave is going to shrink. All right, this is the normal progression of the S and the R wave. Okay, so this is these two things you need to remember in this normal ECG. All right, moving forward. So the abnormalities of the QRS complex can give you a smaller QRS complex or very large QRS complex. Okay, Mariam said, can you repeat the concept? Okay, basically in the V1 you are going to uh, get larger S wave. In the V6 you are going to have a larger R wave. Okay, in the V1 larger S wave, in the V6 the larger R wave. So the normal progression from the V1, V2, V3, V4 is going to have a greater S wave and smaller R wave. All right. Okay. So the QRS complex can have two things. Either very large QRS complexes more than 0.12 second, or very narrow QRS complex or small QRS complex then can occur in the any infiltrated diseases, that can occur in the large pericardial effusion, that can occur in the amyloidosis or sarcoidosis. And if you are going to have a large uh, QRS complex are very large voltage, first thing you need to check for the normal voltage. If it is 10 or less than 10, if it is less than 10, then yeah, you can have a large QRS complex. Or in the hypertrophy, you are going to have again a large QRS complex. So I think these are for not you guys. This is for the postgraduate level. Let's move on. So the T wave abnormalities we have already discussed can occur in the hyperkalemia, can have tented T waves, can have inverted T waves, could be due to ischemia, could be digoxin or pericarditis, can have a biphasic T wave again in the valence sign in the ischemia. Generally not for you guys, this is for the advanced level, so we will discuss is it some time later. Just to show you guys, this is the normal T wave, and let me just move ahead. Okay. Now you can see here clearly appreciate that someone have pinched the T wave and pulled up, like someone pinched it to show a large tented T wave. This is basically you can get it from the Life in the Fast Lane or in the. This is also included in my book, so I'm going to tell you details of that in the end. So this is the hyperacute T waves again for the advanced level, not for you guys. This is just to show you this is biphasic T wave, just going up and going down. This can occur in the Wellen syndrome. Wellen syndrome is again is equivalent to ischemia, and this is the T wave inversion. Normal T wave is upward positive. This is going to be negative. Okay, now let's come to the interpretation of the ECG. So just to summarize all these things, when you look at the ECG, you need to look at the name of the patient, you need to look at the history of the patient, you need to again then look at the normal calibration. All right, 25 and the 10. And after that you are going to check for the all these things: rate, rhythm, axis. In the next CC I'm going to tell you about the axis. What is the axis? I guess we have skipped that. And then you are going to see a P wave and the QRS complex and the T wave. All right, so this is the sequence you are going to follow in the ECG. So just to emphasize more, if I look at the name is not given, the history is not given. So I'm going to tell you a history. This is a normal male patient, 23 years old male who came for the recruitment in the for the fitness. So you are going to see the calibration. It is normal. Again, then you are going to check for the rate. So I'm going to take this QRS complex, this one, because it is falling on the large box equally. So 300, 150, 100, 75, and it is less than 75. It's somewhere between 75 and 52, around 65 or 65, I guess. So, all right, the rate is normal, and the rhythm, it is sinus rhythm, and it is regular. All right, The QRS complex are falling after an regular interval. So rhythm is also fine. The axis is normally what the showing of the propagation of the vector. Vector is nothing but the propagation of the electrical activity. So the SA node is somewhat here in the right atria. The AV node is somewhere between the four quadrants of the heart, and then the bundle of phase. So the vector of electrical activity is going like this one, and in the lastly the apex is going to be activated. So the vector is going this and this one, this side. In the Ethiopian triangle, it generally is between from minus 30 to plus 90. Not for you guys if you are coming in the residency, or after the residency in the specializing in the cardiology, then you need to remember all these things. So generally a vector is basically the axis, or the axis is shown by one and two lead. If both lead are positive, the axis is normal. All right, simple things to remember. If one and two lead are positive, then axis is normal. All right. So moving forward, now we are coming to few cases that are commonly these are presenting in the in the what you can say in the emergency department. So anyone can tell me regarding this ECG? Don't need to worry. Nobody is going to judge you. If anyone is going to answer, even you can write in the chat box. If you are not comfortable speaking, that's fine with me. If you can find any abnormality also with the sequence. Do you want me guys to zoom a bit? All right. So anyone? No one? All right. Let me just tell you regarding this ECG so you can attempt the next one. All right. So normally you are going to start with the name and the history. The name of the patient is given above, Haji Dino. All right. The history is this patient is 60-year-old male smoker and came with the acute chest pain of the 2 hours, and patient had perspiration. Looking at the ECG, what you are going to see again, you are going to check for the normal calibration, which is given somewhat here the lower side, which is normal, I guess. And you are going to check for the rate. So if you start counting here 300, 150, 100, 75, 60. All right. The heart rate is normal. Part of the rhythm, there is P wave, which is sinus, and it is regular rhythmic. This QRS complex falling on the same side. All right. But you can appreciate the PR interval is looks like prolonged. Let me just zoom in to see a PR interval. So starting from the here PR interval, it is more than 200 millisecond. This is more than five small boxes. Like starting from here to here, that is six. That is 230, 220. So the PR interval is prolonged. So PR interval prolongation tells you about the first degree heart block. So the patient have block also. So the trick regarding the chest pain, if someone is coming with the chest pain, you need to look at what the ST segments, as we have already discussed. So the ST segment of this patient seems what? Are they above the baseline? Are they below the baseline? Or they are on the baseline? What do you guys think? Do the ST segment seems normal? So the ICRA have rightly said it is elevated. So ICRA, what do you think the patient is having myocardial infarction? Yes or no? Yes, very rightly said. The patient is going to have an ST elevation MI. All right. So this is very much abnormal. The 2, 3, and AVF. Can anyone identify which kind of MI this patient have? Is it anterior wall MI? Is it lateral wall MI? Is it inferior wall MI? Inferior wall. So, yes, yes, you are right. The inferior wall MI is represented by the ST elevation in the lead 2, lead 3, and lead AVF. All right. So the ST elevation of 1 mm in the two contiguous leads. Contiguous leads are basically showing the same territory. 2, 3 AVF is going to show you the same territory of the inferior wall. So it is going to be ST elevation in the inferior wall. The anterior, if someone have anterior wall MI, they are going to have ST elevation in the precordial leads from the V1 to V6. All right. But you here you can see there is ST depression in the anterior leads. So this is normal in any STEMI patient. STEMI patient can have a reciprocal ST depression. For you guys, for undergraduate level, just remember the ST elevation of the 1 mm is equivalent, showing in the same territory of the leads. It is going to you label this patient as ST elevation MI. So one advanced thing, if you want to remember, if an ECG of this is shown to you, the next thing you are going to check for the RV infarction, which is done by the right sided ECG, and posterior wall ECG, which is going to show you posterior wall MI. All right. Not going into details for not going into details for that. Just remember ST elevation of the 1 mm in the two leads showing of the same territory is going to have an myocardial infarction. The lateral wall, for your simplicity, lateral wall is shown by 1 AVL and anterior wall MI is shown by from V1 to V6. All right. So anyone question? I have a question on this ECG. This is very much common ECG. This is very, 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 very important. I like to emphasize on this very much. You are going because this, if you see an ST elevation, there is going to be a protocol initiated. You are going to give aspirin to the patient. You're going to give a P2Y12 inhibitor like clopidogrel to the patient, or ticagrelor or any availability, and you are going to move the patient for the PCI capable hospital because primary PCI, percutaneous coronary intervention, is going to save lives. Your myocardial infarction is not going to be stunned. You are not going to have permanent damage on the heart. That's why that is important. All right. So this is very much important. Okay, moving next on the next ECG. Okay, so this patient is so the AVL is showing in the negative in the previous ECG. Okay, let me check. Yes, AVL is going to showing you a negative P wave and negative and ST depression here. ST depression is going to be a reciprocal and on that, and this patient have a biphasic P wave going up and down. This could be due to and also an ectopic foci that is generating this kind of impulse. But I think this is fine. You are going to see the AVR. AVR is negative, so this is not any limb lead reversal, right? Okay, so this patient is Salma, a 60-year female. who came with the complaint of dizziness and a history of syncope. All right. So, anyone would like to comment on what you are going to see in this? Is it sinus rhythm? Is it sinus rhythm? Sinus rhythm basically means it is the SA node is firing, and the normal electrical activity is coming from the SA node. So anyone would like to comment whether we have a sinus rhythm or not? Okay, this is sinus rhythm. You can clearly appreciate in the history of syncope. Going to check the rate, but the rate is irregular. You see, these two QRS complexes, RR wave is smaller, and this RR complex is larger. Right? So this is larger, this is smaller. So it is clearly an irregular rhythm. All right. So then if rhythm is irregular, you are going to check for what? Any blocks. All right. So this is the normal P wave, and this is the QRS complex. This is a P wave. This is a QRS complex. This is the P wave here after the T wave. You can see. Let me zoom in so that you can see clearly. So this is the P wave. Can you appreciate the P wave? But after the P wave, there is no QRS complex. All right. So this is no QRS complex, and this kind of block is called as Mobitz block. So there are two kinds of Mobitz block: Mobitz type 1 and Mobitz type 2. Mobitz type 1 is going to show you that PR interval is going to be prolonged slowly, and there is going to be a drop beat. The QR is going to be vanished. And in Mobitz type 2, there is going to be a normal PR interval, and the QRS complex is going to be dropped on a certain interval. So if you are appreciating this, this PR interval is short. This PR interval is shorter. This PR interval is larger. Okay, you are. Let me just. Can you see now? Can you see the cursor?